Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 12. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. We're going to have our lecture on diagnosing and delivering news of cardiovascular kidney metabolic disease. And we have Erin Maikos from Professor of Medicine and the Director of Women's Cardiovascular Health and the Associate Director of Preventative Cardiology at Johns Hopkins, who will be giving this great lecture today. So Erin, go ahead and introduce yourself.
Hi, everybody. I'm looking forward to speaking with you today.
Great. And now we're going to introduce our great panelists today. So Dr. Gail Newlundy-Bland, could you go ahead and introduce yourselves?
I'm Dr. Gail Nunley Bland. I'm the director of the Diabetes Center at Howard University Hospital, one of the endocrinologists practicing there in Washington, D.C.
And we are really excited to have Emer McKenna, one of our naturopaths from Health Point Community Health Center, giving the case today. Go ahead and introduce yourself.
Hi everyone, my name's Emer McKenna. I'm a PCP at HealthPoint and CTAC. I use they, them pronouns.
And we're really excited as well because of Emer's case to have Dr. Emily Fay from Maternal Fetal Medicine also joining us today. Emily, can you introduce yourself?
Hi, as Nicole mentioned, I'm Emily Fay. I'm a maternal fetal medicine specialist at UW here in Seattle. And in particular, I specialize in diabetes and pregnancy.
Thank you so much. And Erin, go ahead.
Okay, great. So I'm going to be focusing on the diagnosis of CKM and of course, how to deliver the diagnosis and also the therapies that would be appropriate to discuss with patients as part of shared decision making. These are my disclosures. And these are the learning objectives. So there is tremendous overlap in the whole CKM spectrum. About 35 to 45% of patients with heart failure also have kidney disease. 20 to 44% of patients with type 2 diabetes have kidney disease. As a cardiologist, I see that 76% of patients who have cardiovascular disease and diabetes also have CKD. About 12 to 45% of patients with heart failure have diabetes, and about 14% of the US population has diabetes. So there's tremendous overlap in the whole CKM spectrum. So you may be aware that at least 2 years ago, the American Heart Association released this nice scientific statement about the stages of CKM syndrome, where stage 0 is no CKM risk factors. And so this is where we hope our patients can be by really focusing on preserving cardiovascular health, primordial prevention. Stage 1 even just starts with adiposity. There is unfortunately, no such thing as metabolically healthy obesity, that individuals with obesity, they have higher risk, even without the traditional risk factors, compared to individuals who have a normal BMI. Stage 2 already manifests in some of those metabolic risk factors and CKD in this stage as well. Stage 3 is when there's already evidence of subclinical disease. So this may be subclinical heart failure that you may see on echocardiogram with diastolic dysfunction or having an elevated biomarker like BNP, or evidence of subclinical disease such as the presence of coronary calcium, which is a marker of subclinical atherosclerosis. And stage 4, there's actually been a clinically manifest event that they've actually had a CVD event or heart failure. So obviously the best intervention is prevention. And so intervening hopefully earlier, we can implement both lifestyle preventive therapies to slow progression down this pathway. So starting with diabetes and prediabetes, I think you're aware that heart disease rates are about 2 to 4 times higher in adults with diabetes than those without diabetes. Stroke anywhere for 2 to 6-fold higher in persons with diabetes than persons without diabetes. And having the presence of diabetes is associated with a shorter lifespan than individuals without diabetes by approximately 8 years. Now, there's been just this revolution that we now have therapies that actually, regardless of A1C, can substantially reduce cardiovascular and kidney outcomes in persons living with diabetes. These drugs were initially studied for cardiovascular safety, and we found that not only were they safe, they had these amazing cardiovascular benefits, with the SGLT2 inhibitors being shown predominantly to reduce heart failure hospitalizations and cardiovascular death, as well as reduce kidney disease progression, and the GLP-1 receptor agonists reducing the risk of major adverse cardiovascular events. So there were these cardiovascular outcome trials in persons with diabetes, and this is the meta-analysis of these trials, and we see, aggregated together, that GLP-1 therapy in persons with diabetes is associated with a 14% reduction in major adverse cardiovascular events, a reduction in cardiovascular death, as well as a 17% reduction in stroke. And we also saw this trend for significant benefit in kidney outcomes, and that's what led to these dedicated kidney outcome trial, the FLOW trial. So I was part of some statements that was at least updated last year called the DCRM, the Diabetes Cardiovascular Risk Metabolic Syndrome Multi-Specialty Practice Guidelines, where we give recommendations as part of a multidisciplinary global team across all of these CKM diseases and risk factors. So here's our slide for type 2 diabetes. And we really, of course, prioritize the therapies that have cardiorenal benefit, the SGLT2 inhibitors and the GLP-1 receptor agonists. And whatever one you sort of start first, you may choose based on their underlying comorbidities. So the agents we prioritize are in the green, and those therapies in diabetes that are in blue and yellow are less prioritized. And we emphasize the importance, of course, as individualized goals in terms of A1C control, that you might likely want to target a much lower A1C in healthier individuals with few comorbidities. But patients who are frail, complex, have issues with hypoglycemia, you may have a more liberal or less intensive A1C target. So not only do we want to prevent and treat diabetes, it's really important that we do this sooner, that there is the duration effect. That's not only how high one's A1C is, but the more years they've been living with diabetes, the more at risk for cardiovascular disease. So this is one of our studies from the ERIC study, where we adjusted for their current A1C, their current glucose control, as well as all the other cardiovascular risk factors like blood pressure and lipids, and saw that just years alone, the years that they were living with diabetes, was linked to their greater risk for heart failure. So it's really important that we try to prevent diabetes in the first place. And this is a very old study now from 2008, the STENO2 trial, but really again emphasize that when we're talking about cardiovascular risk management and diabetes, this is not just all an A1C centric focus. This is really a multi-pronged approach addressing blood pressure, addressing lipids, with intensive therapy across multiple CV risk factors and reducing risk of cardiovascular outcomes. And then prediabetes is becoming exceptionally common. Almost 1 in 3 adults now have prediabetes, manifested with either a fasting glucose between 100 and 126 or an A1C between 5.7 and 6.5. And prediabetes itself has been linked to increased cardiovascular and kidney disease risk. And so our goals, of course, is try to prevent progression of hyperglycemia and reduce their cardiovascular and kidney risk. And like all the things we'll be discussing, this is really tailored to the individual person. If they are living with obesity, focusing on weight reduction therapy, and then adding additional CVD preventive therapies as needed. But we want to try to slow the progression to type 2 diabetes. So obesity, as I showed you from that CKM spectrum, is sort of central in this with stage 1 of the CKM spectrum. And it's, of course, a major health problem that 71% of US adults are living with overweight or obesity, with 41% of adults living with obesity. And so this is, a very serious chronic disease, but it is treatable, but it's complex, as it's influenced by genetics, hormones, and the brain, environment, and social factors. It's estimated that 70 to 80% of our BMI is determined by genes. And then there's a gene environment interaction where certainly we're all living in an obesogenic environment with a high access to processed foods and the way we work and way we commute being more sedentary. And so this genetic susceptibility can be manifest. But it's really important that we understand that this is really more about chemistry than any person's individual character, and that we approach management of obesity in a non-stigmatizing fashion once we understand that a lot of weight control is beyond patient's volitional control. So it's much more complicated than just calories in, calories out, although reducing calories is still an important mainstay for weight loss. But it's important to know that the brain really regulates the weight set point, kind of like a thermostat. So obesity is a brain-related disorder. And when this weight set point gets dysregulated in the hypothalamus by biological environmental factors, these feelings of hunger and satiety can be affected. So there is a strong drive for the brain to defend one's highest fat mass. which is why weight gain is so common in these weight loss studies. Over 80% of people who lose 5% or more of their weight regain it over 5 years. So that's, in that background, when we have to have sympathy and understanding to this struggle with our patients living with overweight and obesity. But it is important that we address it because the long-term consequences of obesity are profound on almost every organ system, including substantial risk of cardiovascular disease, liver disease, cancer risk, of course, the risk of diabetes, the risk of kidney disease, and the risk of brain complications. So obesity is a heterogeneous chronic disease. And so when approaching the patient living with obesity, it's important that we screen for other CKM risk factors that are often comorbid in persons living with obesity and see if they have any of the organ damage, the organ complications from obesity. And then we'll come up with a tailored approach. Our goal is to improve their health, their quality of life, and decrease the risk of developing obesity related complications. And then we coming up a shared treatment goal based on their underlying risk and their cardiometabolic goals. Understanding weight loss therapies, with lifestyle changes, anywhere from maybe 2 to 10% weight loss can be achieved with lifestyle interventions. With some of the older anti-obesity medicines, up to maybe 10% weight loss. With the GLP-1 receptor therapy, some of the older ones like liraglutide, about 8%, but with the sort of more potent GLP-1s, anywhere from 12 to up to 24% when you're thinking about some of the triple agonists that are coming down the pipeline. And of course, there's still surgical therapy as an option, which can achieve 25 to 30% weight loss. So it is important that we treat obesity, particularly in individuals at high cardiovascular risk. And we now have a cardiovascular outcome trial in persons who have overweight or obesity with a BMI above 27, who had established cardiovascular disease. So this was a secondary prevention trial, but they did not have diabetes. Many had prediabetes, but they did not have diabetes, and showed that semaglutide at the weight loss dose of 2.4 milligrams per week was associated with a 20% reduction in major cardiovascular events, as well as there was a reduction in all-cause mortality and improvement in kidney outcomes. And so, this was sort of proof of concept. We already knew since 2016 with the LEADER trial that GLP-1 therapy, was a cardiovascular prevention agent in persons with type 2 diabetes. And now we showed that this can reduce cardiovascular outcomes in persons without diabetes, but at very high cardiovascular risk who have overweight, obesity. And the SURMOUNT MMO trial, which was tirzepatide, is ongoing. So we approach addressing obesity or adiposity-based chronic diseases similar like we would approach a patient who for smoking cessation. And again, in a non-judgmental, non-stigmatizing way, kind of following the 5 A's to ask if we can discuss their weight, but really from the goal of that we want to improve their health, improve their quality of life, and we can advise on the various treatment options based on their shared goals and their cardiometabolic risk and agree on a plan that we can continually reinforce, again, as part of a team-based approach to care with the patient at the center. And just like diabetes, again, thinking about BMI years, that duration of exposure, that the more years that people are living with overweight and obesity, the greater their cardiovascular risk. And this is one of my studies from the MESA study, which enrolled, adults that were middle-aged to older on average. And after we adjusted for their current BMI and also for all their current cardiovascular risk factors, we just showed that the number of years, the duration, the years that they've been living with an elevated BMI was associated with an increased risk of heart failure, even after we accounted for their current BMI. So while it's never, too late to start treatment, the earlier we can intervene, the more likely we can prevent or delay these downstream consequences. So moving on to the K in the CKM spectrum, chronic kidney disease. This is also very common in U.S. adults. More than 1 in 7, that's 15% of the U.S. population, are estimated to have kidney disease. If you look at older adults over the age of 65, that's like 38%, so very prevalent. But as many as 9 in 10 adults with CKD don't even know they have CKD. And about 2 in 5 adults with severe CKD don't know they have CKD. And I see this a lot. I'm a cardiologist, and I'm very often the first person to tell the patient or, that they have CKD, or at least the patient tells me that they were never aware. And so this is a really missed opportunity, especially since we have a lot of opportunities for prevention, especially because 3 in 4 new cases of kidney disease come from these big cardiometabolic risk factors, diabetes and hypertension. Those make up most of the etiology for kidney disease. And those are also, of course, preventable and treatable risk factors. But to diagnose, you need to both look at eGFR and measure urine albumin creatinine ratio. Both of these measures independently are associated with both cardiovascular mortality and all-cause mortality, both in persons with diabetes in the red and no diabetes in the blue. So these are predictive in people without diabetes as well. And so, of course, as the eGFR falls, you have higher cardiovascular and all-cause mortality. And then with albuminuria, the greater the albuminuria, the greater the risk of mortality. And so in terms of diagnosing and defining CKD, you have to measure both, to be chronic kidney disease, that this has been present for at least 3 months. So we don't make it on a single value, but there's the KDIGO heat map. And I have this printed out in my clinic. It's a good way to talk to patients who are often very unaware about their CKD. The colors refer to the risk of kidney disease progression, but this also kind of overlaps with the risk of cardiovascular disease. And so this is, again, you need to measure albuminuria or you will not be able to fully stage CKD, and you'll miss a lot of CKD if you look at GFR alone. And so measuring urine albumin creatinine ratio is a quality measure. It's a HIDUS measure in persons with diabetes, and it should be done annually in persons with diabetes along with eGFR. But we know in persons with diabetes, only 50% of persons with diabetes have an albuminuria measured once a year. So as we're doing not very good at actually measuring this. And this is with persons with diabetes. I also measure urine albumin in persons at high risk for CKD, including those with hypertension and cardiovascular disease. Even if they don't have diabetes, I showed you the risk is similar associated even in persons without diabetes. Now, in the outcome trials, the cardiovascular outcome trials in persons with type 2 diabetes evaluating SGLT2 inhibitors, we had seen that SGLT2 inhibitors reduce the risk of cardiovascular outcomes, heart failure hospitalizations, and cardiovascular death in persons with diabetes. And this led to 3 dedicated cardiovascular outcome and kidney outcome trials in persons with CKD. The Credence trial, was the first and enrolled patients who had diabetes and CKD and albuminuria. But both DAPA-CKD and EMPA-CKD enrolled persons with CKD with or without diabetes. And EMPA-Kidney was sort of the broadest trial, including patients who didn't even have albuminuria if they had a very low eGFR. And what they showed is SGLT2 inhibitor therapy significantly reduced progression of kidney disease by 30 to 40% and also reduced cardiovascular outcomes. And as such, KDIGO chronic kidney guidelines now prioritizes SGLT2 inhibitors as foundational therapy in persons living with CKD, which is why we need to identify CKD so we can prevent progression and slow progression of complications. Now, as I also, mentioned, of course, in the cardiovascular outcome trials in persons with diabetes for GLP-1 therapy, there was this signal for kidney benefit. And this led to the first dedicated kidney outcome trial with a GLP-1 in persons with type 2 diabetes and with albuminuria, the FLOW trial, and showed that semaglutide, at the diabetes dose, the 1 milligram per week subcutaneous dose, significantly reduced this kidney primary endpoint, this kidney cardiovascular endpoint by 24%. Not only that, it met all the hierarchy, reduced cardiovascular outcomes, reduced the kidney outcomes alone, and even reduced all-cause mortality. So very exciting because for the longest time, all we had for CKD was ARB therapy. And now we have evidence for SGLT2 inhibitors, GLP-1s, and also for the non-steroidal MRA, finerenone, in persons who have diabetic CKD. So early intervention is important because often nephrologists don't get referrals for CKD until there's like 2 nephrons left when the eGFR is less than 30. So most of CKD is going to be presenting in primary care or perhaps in my clinic in cardiology. And so we need to identify this early. Early intervention is the key. If you look at this curve, if you intervene when the eGFR is already very low, less than 30, these therapies, you might be able to extend three more years before progression to sort of the end stage kidney disease. But if you start these therapies early, potentially you could add, 11 more years of freedom from significant CKD progression. And so this is why the best intervention is prevention and why we should be identifying CKM risk and treating early rather than waiting to there's already advanced CKD. And so as part of this same DCRM multi-specialty guidelines, we emphasize that CKD is a risk-enhancing factor for cardiovascular disease. We want to try to prevent CKD if possible, but identify it when it's present and slow its progression. And that, again, is a multi-pronged approach focusing on blood pressure control, glucose control, lipid control, reducing albuminuria. Of course, we have to screen and diagnose it first. And then in patients who have CKD with diabetes, we have a pillar approach, kind of like we do for heart failure, with the maximally tolerated renin-angiotensin blockers like ACE and ARBs, SGLT2 inhibitors. The nonsteroidal MRA, finerenone, has evidence of kidney cardio benefit in this population, and GLP-1 receptor agonists. And then in CKD without diabetes, again, your RAS blockers, SGLT2 inhibitors. There is some suggestion that nonsteroidal MRAs and GLP-1s may help in this population too as well, but we don't have a dedicated outcome trial in this population without diabetes. And then I want to move to HFpEF as part of the CKM spectrum under the cardio risk. And again, just like kidney disease and prediabetes to diabetes, everything's on a spectrum. And so, sort of stage A is just people who are at risk for heart failure. So this is your primary prevention group, that people have risk factors like hypertension or diabetes, where we want to they're at risk for heart failure and try to intervene by treating some of these risk factors. Stage B, this is your subclinical heart failure, where they already have, echo imaging suggesting they have diastolic dysfunction, or they have elevated BNP, they already have evidence of clinical disease. Stage C, they've now developed symptoms, and stage 4 is really advanced heart failure. So you may be seeing patients in your clinic who are at stage A and stage B that you can help intervene. Because we know that there's sort of this bi-directional association of risk between heart failure and kidney injury, and sort of this downward spiral where one begets the other and so forth. In the setting of heart failure, the heart can't meet the metabolic demands. And so there is this activation of compensatory mechanisms like activation of the sympathetic nervous system, activation of the renin-angiotensin-aldosterone system, and this can lead to further kidney injury and inflammation, and this kidney injury leads to more RAS activation and leads to more heart failure risk. And so therapies that can improve heart failure can also benefit the kidneys as well. So going back to SGLT2 inhibitors, again, the landmark trials in persons with type 2 diabetes, EMPA-REG, CANVAS, and DECLARE, had showed that SGLT2 inhibitors in persons with diabetes at high risk, high cardiovascular risk, actually decrease the risk of developing incident heart failure. And this had led to then dedicated heart failure trials in persons with heart failure, both with reduced ejection fraction and preserved ejection fraction, as well as there was also some studies in patients hospitalized or with acute heart failure, so not just your chronic outpatients, and showed that SGLT2 inhibitors significantly reduce cardiovascular events and heart failure hospitalizations in person living with heart failure. I'm going to focus on HFpEF because that's the one that's most strongly linked sort of in the CKM spectrum, and also the one that's less likely to be diagnosed. HFrEF, obviously an echocardiogram which showed reduced ejection fraction. PEF can be more challenging, but it's an increasingly common cause of exercise intolerance or chronic unexplained dyspnea, and it's very much linked to obesity and sedentary behavior. And some studies, like the ERIC study, suggested that in older adults who had unexplained dyspnea, no other cause of their shortness of breath were found, that 35% had these high risks of scores suggesting that they had HFpEF. So there's a few scoring systems out there. I'm including the H2FPEF score because it's the most simply and clinically easy to apply and doesn't need biomarker testing, which may or may not be available. So this was a score that was derived and validated against right heart cath data to look at filling pressures, but it looks at features like having obesity, being on 2 antihypertensives, having AFib, having pulmonary hypertension with an RVSP above 35 on echo, being older, and having high filling pressures on echo, an E over E prime ratio greater than 9. And if you have 6 of these points, it's highly diagnostic of HFpEF. And so this is a diagnosis, if you have a patient, particularly if they have risk factors like hypertension, obesity, and have unexplained dyspnea, this could be applied in a clinic setting that even, individuals in primary care can identify and hopefully start patients on treatment. And, HFpEF is heterogeneous. There are some different types of HFpEF, including the hypertensive phenotype, but the obesity phenotype is actually the majority of patients with HFpEF these days, and these are more unique. Patients with obesity phenotype of HFpEF have more plasma volume, they have more stressed volume, they have more concentric left ventricular remodeling, they have higher prevalence of hypertension, they have more right heart dysfunction, they have more epicardial fat around the heart that leads to kind of a constrictive physiology, and they're more diuretic resistant, so they can be challenging to treat. And they also, all these things above mean that they're actually more symptomatic and they have poorer functional capacity and more severe quality of life. And we're now understanding that overweight and obesity are not just mere bystanders, but actually probably are causally related to the progression of HFpEF. And so I emphasize this because very often I see patients who are living with overweight and obesity, and they're just told that their breathlessness and their poor exercise tolerance is just due to their weight. But they may have been at the same weight for a long time or even at a lower weight, and yet their symptoms of shortness of breath are new. And so often HFpEF is not, adequately diagnosed. Well, I mentioned now we have the SGLT2 inhibitors, which we have 2 landmark trials showing that they were effective therapy for HFpEF, which was a game changer because prior to the SGLT2 inhibitors, we really didn't have any therapies for HFpEF that had positive outcome trials. We had lots of things for HFrEF, reduced ejection fraction, but nothing for HFpEF. So now SGLT2 inhibitors entered the scene, as I mentioned, and then the latest therapy to offer some hope for and help for our patients with HFpEF living with obesity are the GLP-1 receptor agonists. So the STEP HFpEF trials, they were 2 parallel trials with or without diabetes designed to have pooled results, enrolled patients who met the clinical criteria of HFpEF and had a BMI above 30 and evaluated semaglutide 2.4 milligrams per week versus placebo and showed significant improvement in their quality of life. This Kansas City cardiomyopathy clinical summary score, the higher the scores, the better quality of life. So this is a big change. They had a lot of improvement in their quality of life. They did lose weight. Again, this wasn't a dedicated weight loss trial, but they did lose weight with GLP-1, 8%. And they had the significant reduction in risk of heart failure hospitalization, although this was a secondary endpoint, but very encouraging. And because this was so positive, this actually led the SUMMIT trial that was evaluating tirzepatide to actually change heart failure hospitalizations to a primary outcome. And this was published recently. This is patients, again, with HFpEF and obesity, BMI greater than 30%, evaluating tirzepatide, our dual agonist, GLP-1 and GIP, and showed that there was an improvement in that quality of life score, but really notably a 38% reduction in the primary outcome, which included death from a cardiovascular cause or worsening heart failure event. So these therapies are not just weight loss drugs per se. These are, cardiovascular prevention and treatment agents. It's still a little debated about how much this benefit is entirely due to the weight loss, which was about 12% in the study, or how much is there actually disease modifying effect of GLP-1, but patients feel better and they do better with these therapies. So for the primary care clinician, you can make the initial diagnosis of suspected HFpEF by, using those risk scores, and you can, start some of the treatments for HFpEF, diuretics if they're congested, and be thinking about SGLT2 inhibitors and GLP-1 receptor agonists as appropriate. So when do you need to refer on? Since HFpEF can be diagnosed in primary care, well, certainly, if the patient also has comorbidities like atrial fibrillation, coronary disease, collaboration with the cardiologist is good. If the patient has high-risk features, like they're being hospitalized for their HFpEF, or they're having RV, right ventricular dysfunction on echo, again, referral to cardiology. If they need extensive evaluation, like this diagnosis is not clear and they need exercise testing, sometimes they don't have pulmonary hypertension at rest, and we do an exercise diastolic test to see if we put them on a bike or treadmill, if they develop exercise pulmonary hypertension, or if they need a right heart cath. Obviously this all can be managed by cardiology. If they have cardio-kidney syndrome, where the HFpEF is affecting their kidneys or vice versa, or if there's some suspicion that there's something else going on, these mimickers of HFpEF like amyloid, hypertrophic cardiomyopathy, or valvular pericardial disease, or if the patient is needing increasing doses for diuretics, accelerating diuretic needs, or they have more advanced symptoms. They're no longer, class 2 with mild symptoms, but they're more moderate to severe symptoms. That's when making a cardiology referral. And so I'm just in the last minute, I could give a whole talk on this, so I can't do this justice. But of course, lipid management is also an important cornerstone for ASCVD prevention. We have new tools and new targets in the new era. And so patients at very high risk who have established ASCVD at high risk, such as those who've had a prior MI or stroke, our goal is not only to lower LDL by 50%, but to achieve this risk-based target of less than 55. If they have multiple events, we even try to get it less than 40. If they have ASCVD, but not at very high risk, they have had coronary disease, but haven't had an MI or a stroke, we aim for LDL less than 70. Or if they have diabetes that are high risk with, at least one or more risk factors, we aim for an LDL less than 70. And then for high-risk primary prevention, an LDL less than 100. With statins being the first-line therapy, of course, but now we have a number of non-statin therapies that can help our patients achieve these targets. And it's really all about the LDL lowering. Both with statin and non-statin therapy, we see for every 1 millimole per liter lower LDL, which is about 38% lower milligrams per deciliter lower LDL, we see a 22% reduction in major adverse cardiovascular events. So lower is better. There's no LDL that's too low. We see a benefit all the way down to 10. Now, triglycerides are not a primary target of therapy for cardiovascular risk reduction, although they can be a marker of a patient at higher cardiovascular risk. Certainly, if the triglycerides are severely elevated, more than 500, and particularly above 1,000, they're at risk for pancreatitis, and we want to reduce that risk. A low-fat diet and then fibrates may help in this group prevent pancreatitis. But fibrates, unfortunately, have not been shown to reduce cardiovascular risk. In patients with mild to moderately elevated triglycerides, we want to focus first on a statin to treat their LDL and ApoB related risk. And then there is data from the Reduce It trial that in persons with established ASCVD or diabetes with risk factors who are on a statin and remain with mild to moderate hypertriglyceridemia, they might benefit from icosapent ethyl. Unfortunately, other omega-3 supplements, both prescription omega-3s and also dietary supplements, have not demonstrated this cardiovascular benefit that was seen with the pure EPA in icosapent ethyl. And then in primary prevention, again, be thinking about these risk enhancing factors. Not so much a huge fan of these 10-year risk calculators because they they don't include a lot of things, and they're really focused on 10-year risk. And then young adults, we really think about lifetime risk. And so there's a lot of things not in the calculator, but if they have these risk enhancing factors like family history, having an LDL above 160, certainly if their LDL is above 190, that's already a class 1 indication to treat. They have chronic inflammatory conditions, South Asian ethnicity, metabolic syndrome, chronic kidney disease, or other biomarkers like having a high lipoprotein(a) above 125 nanomoles per liter, or having a high CRP above 2, or female-specific factors like early menopause or history of preeclampsia. This all puts people into a higher risk category that would favor the initiation or intensification of lipid-lowering therapy. And then when there is uncertainty, you can get an imaging test to look for subclinical atherosclerosis, like a coronary calcium score. As plaque is building up in the arteries over time, it can become calcified or hardened, and calcium can show up bright on a non-contrast study. But keep in mind that calcified plaque is late-stage plaque. So when it's present, it's definitely a risk marker like, hey, there's plaque there. So we should definitely be thinking about treating the patient's atherosclerosis. But, it's not as useful of a test in younger adults because if they have any plaque, it may not be, not calcified. And so in patients with very high LDL, like above 190 or high LPA, or there might be lots of reasons to still treat a patient with a statin, even if their calcium score is 0. A calcium score of 0 is lower risk, but not no risk. And then be thinking about a life course approach that, I talked about diabetes years and BMI years. And so be thinking about cholesterol years, that it's not only how high someone's cholesterol is, but the more years that have been exposed, the more years that their arteries are marinating in this high concentration of lipoproteins. And so if there is this theoretical threshold where you see the onset of clinical ASCVD, some have said that's about 5,000 milligrams per deciliter per year. If someone has severe primary hypercholesterolemia, LDL is above 190, high cholesterol from birth, if left untreated, they will cross the threshold of onset of ASCVD at a young age. 30% of women with FH untreated will develop an MI before age 60. And so this is why all adults, yes, even 20-year-olds, anybody who has, severely elevated cholesterol need to be treated. Now, individuals with lifelong low LDL from favorable genetics, healthy lifestyle, or perhaps treating LDL earlier in age, they may never develop the onset of clinical ASCVD. But I think more attention needs to be paid to those with mild to moderate hypercholesterolemia. These, individuals are often kind of ignored, and that, with enough years of exposure to these mildly to moderately elevated levels, they too have earlier onset of ASCVD than their counterparts with lifelong low LDL. And then I don't think I have much more time, so I won't really get into, blood pressure management. Hopefully that's all been covered before, but we do want to aim for a blood pressure less than 130/80 and make sure that we, look for resistant hypertension and pseudo resistance and, and metabolic associated fatty liver disease. Again, this is a whole conversation of itself. So I would just, again, say that these patients in the CKM spectrum that have diabetes and these other metabolic risk factors are at high risk for MASLD. D. So be thinking about screening for them and be thinking about, these risk calculators like FIB4. And, if they have elevated scores, they'll need additional, imaging and consider referral to hepatology. So all of these slides are in this document available for review. And then, of course, lifestyle is on the foundation of all our preventive efforts. And while we have recommendations such as, at least 150 minutes a week of moderate exercise activity per week and other lifestyle changes, 7 to 8 hours of sleep, any effort that a patient can make to this, any strides of improvement, even if they can't do all of these things, any effort is worthwhile, and this should be addressed at every visit. So my last slide is that this is a shared decision process. The patients need to take ownership of their self-management. We need to understand their priorities, emphasize the importance of early treatment, understanding, their own, affirming that they can control their health outcomes, empowering the patient. We do want to educate at every visit. We can't cover all these topics at every visit. So we'll pick, the topic of the visit, but, repeat and reinforce. And all of this is through the lens of, non-judgmental, non-stigmatizing approach and really tailoring to the patient based on their health risk, their health literacy, their social determinants of health to try to help them optimize their adherence. And that all of us need to take ownership of identifying, diagnosing CKM's diseases and implementing therapy. That this is, no longer just in the realm of endocrinology, but really is in the realm of all of us, whichever one is interacting with the patient first, to be really thinking about implementing these CKM therapies, which of course include lifestyle. So the risk factors for CKM, include these obesity, prediabetes, diabetes, hypertension, dyslipidemia, metabolic syndrome, they overlap. CKM diseases have bidirectionality of risk. Weight loss can substantially improve multiple CVD risk factors and reduce the risk of CVD complications, but the time is ticking. The longer duration of exposures confer greater CVD risk. So we all need to overcome inertia, early diagnosis, early implementation of prevention, of course, addressing social determinants and empowering patients and utilizing a multidisciplinary team. So I stop there and I look forward to the case.
Thank you so much for that great broad summary and lots of great teaching points. There was a question in the chat about How often do you see people have screening for protein in the urine if they just have hypertension but without diabetes in your clinical practice?
Well, I think it's not done at all very often. So this is why I'm often the first one doing it. Hypertension is a major risk factor for CKD. And, the studies show that albuminuria, is associated with cardiovascular risk in persons with or without diabetes. So I screen in any person who is at risk for kidney disease because we have therapies that we can intervene. It's not, the highest measure like it is in diabetes. So, in diabetes, where it's actually quality measures, only done 50% of the time. So I think it's really done a lot less in persons with hypertension. But I would encourage you to do it because if we identify kidney disease early, we have these therapies that can help.
Great summary on that one. Now, there's another question about lipoprotein little a. Do you ever repeat it? That was their question. Sometimes patients are requesting it be repeated.
Yeah, so I was part of a National Lipid Association statement that we endorse, similar to what the European guidelines, the Canadian guidelines say, is to measure lipoprotein little a at least once in someone's lifetime. So everybody should have it checked at least once in their lifetime. Now it's 90% genetically determined. So if somebody is really, really normal, we don't need to really measure it again. A healthy level is less than 75 nanomoles and a high risk level is above 125. So there is a group in the middle called the 75 to 125 that's intermediate risk. There are some non-genetic factors that can bump it up, like a woman transitioning through menopause, the loss of estradiol, their LPA levels can go up a little bit, or if you develop kidney disease. So if somebody is that intermediate range, sometimes I'll check it again to see if in their risk enhancing range. Otherwise, if there's a high level, we think about therapies to mitigate risk based on how high the LPA level is and their other cardiovascular risk factors. The only other time I repeat it is if I do start a therapy, such as a PCSK9 inhibitor, those therapies can lower LPA about 20 to 25%. So I kind of see if it comes down. Now, there's emerging therapies for LPA that are in trials right now. And if we show, those are successful, these new therapies become available, LPA might be a treatment target in the future, but as of now, it's part of risk assessment, but we aren't treating to target because we don't really have therapies to boost the number. So we aren't really following serial levels, but the purpose of measuring it is even if we don't have therapies to lower the number, we have therapies to lower cardiovascular risk. So if they have high risk because of LPA, we can treat all the modifiable risk factors like treating LDL, healthy lifestyle, all those things to lower their risk. And keep in mind, there's about 10-fold more LDL particles circulating than LPA. So while LPA per particle is more risky per particle, there's more LDL particles. So really focusing on getting the LDL down in these high risk patients with high LPA. So yes, I don't measure it routinely, another time, unless you've concerned that it might have gone up because of some other factor like going through menopause. But if somebody's normal, going through menopause is not going to put them from normal to that risk enhancing range. And so you probably don't need to repeat it if they were normal.
Great. Thank you so much for that summary. And Dr. McKenna, we're going to let you go ahead and start our case out.
Hey, hi everyone. So this is the case of a little bit of a tricky patient of mine. She is a 39-year-old person. She's an Afghan refugee, although she's been in the country for a few years. And she's had uncontrolled diabetes evidenced in the medical record for as long as we've known her. I inherited her from another PCP that left the practice, and her main concern is wanting to become pregnant. She's pretty resistant to the idea that, it's harder at an older age. She's also really resistant to healthy lifestyle interventions like changing her diet or doing exercise. She does also tend to bop around a little bit to different providers. And I think I might not be her favorite person because I am always trying to convince her to control her diabetes better. And she likes that very much. So she really doesn't like the idea of injecting anything, including insulin or a GLP-1. She prefers oral meds, but I don't think she's very adherent to them when they are prescribed. She makes me nervous a little bit. She has a history of GDM, and she recently did become pregnant and then had an early pregnancy loss. And she is currently trying to become pregnant again. She's taking metformin. Oh, the thing that I was going to say that I forgot is that I tried to get her to come in for a lab draw to get some antibodies related to a possible autoimmune type 1 or 2 diabetes assessment, but I wasn't able to get her in before this presentation. She's taking metformin. That's the one thing that she has been more or less willing to take all the time. I put her on a prenatal, and then she saw another provider who put her on atorvastatin recently. She has no known allergies, family medical history. She doesn't have much information about that. So non-contributory as far as we know. She has definitely had several successful pregnancies in the past, and she has a few kids. I'm not sure exactly how many, and she doesn't drink or smoke. She definitely has quite elevated BMI and high cholesterol and high blood sugar. As you can see, the A1Cs have been poorly controlled for quite a long time. Our policy is to have her on 1 month follow-up for anyone. HealthPoint has anyone with an A1C greater than 9 on 1 month follow-up, but she hasn't been super adherent to that. And so I think my main things that I'm looking for guidance on are, she makes me nervous just because, she's taking some meds that are thought to definitely not be safe in early pregnancy or in pregnancy period. So how do you counsel patients about, if they do become pregnant or think they might be pregnant, stopping medications that are typically used in pregnancy, any oral meds, or how you would approach this case with somebody with pretty low health literacy, likely would not qualify for a CGM as prescribed under insurance, and who is pretty resistant to any form of injectable.
Great case, really challenging. Anyone have any clarifying questions? My question was about, do we have any sense of what a typical meal for her is and how many times a day she's eating?
I'm sorry, I don't have that info right now.
Anything about sugared beverages, just because, understand that culturally she may have specific food she likes to eat, but if we could just focus on something like sugared beverages, or juice, such as juice or something like that, that may actually be very helpful. So,
Yeah, I've definitely talked to her. She likes to drink tea with sugar, and I've talked with her about the sugary beverages thing before. And she, it's hard. It's very hard to tell what she's willing to do in terms of lifestyle and diet. We've definitely talked about it a lot.
and how old was she when she developed diabetes? I saw she had gestational diabetes, but
Yeah, so I think she established at Health Point around 2021, and she had diabetes then. And she came to this country with a refugee visa, and she reported those histories.
and then my last question, and maybe you can't answer it, is since the miscarriage, has anyone discussed with her again her diabetes? Just as, this was probably very hard and challenging, but it may be something that then we can utilize as a positive way of moving forward.
100%. Yeah, I've definitely tried to leverage that. And they definitely came back after the miscarriage and were like, why did this happen? And we had big, long talks about, the body's intelligence in trying to support a pregnancy if it's not able to, versus like uncontrolled diabetes and risk factors. And she and her husband were a little bit slash fairly resistant to hearing that diabetes could be a factor in difficulty becoming pregnant and losing the pregnancy. And I definitely tried to leverage it to try to get her on board with better diabetes control. And I hope that wasn't a factor in alienating her from me. But if I'm being honest, it could have been. I'm not sure. She definitely, after that conversation, started bopping around to other providers instead of coming to me, and she fell off of 1 month follow-up. So
Really challenging case, great information. So just to sort of go forward a little bit on and recap this patient, she is a 39-year-old female with a history of uncontrolled diabetes. It looks like A1C's in the 9 to 10s previously, most recently in the high 9s. And then she wants to get pregnant again, and that's her primary goal. She's currently just on metformin for her diabetes management and recently started on atorvastatin. She has a BMI of 33, an absolute weight of 187 pounds, and lower health literacy, and, obviously some barriers to accessing and engaging with the healthcare system, and maybe some cultural things that we have to be sensitive as well. So, how we always start every case is what type of diabetes and do we think this person is producing insulin, right? And I'm going to throw this over to Gail and ask her, what do you think? Is this someone you would consider more likely to have type 2 diabetes, latent autoimmune diabetes, or type 1 diabetes?
Most likely she has type 2 diabetes. I didn't get a family history of diabetes. Do we know that she has any family history?
We don't really know.
Okay.
Limited health access of her family.
Okay. But, even with obesity, you can still have type 1 diabetes. So, many times when we're having difficulty controlling diabetes, we do screen with antibodies and also look at their C-peptide to see if they're insulin.
Yeah. And I agree 100% with Gail. And I think she probably likely has type 2 diabetes, even though she does have that gestational diabetes. And then she was younger age when she developed her type 2 diabetes. But I might get her GAD antibodies like you're doing early because it is an objectable way of saying your body doesn't make insulin or it's deficient in making insulin, so you need it, right? Anything objective we can show the family to support them may be helpful in initiating the correct treatment for her diabetes. And then we've been discussing the different antibodies in the past, so I just wanted to summarize them. Typically, we draw GAD first, and then in patients who are high risk, so when I have a low C-peptide and my suspicion for type 1 is high, I will draw A and zinc transporter antibodies as additional tests. In someone who is insulin naive, I will screen their family members with insulin antibodies, right? Because once you're exposed to insulin, you will have positive insulin antibodies. And so usually the insulin autoantibodies are used prior to clinical disease or need for insulin. But those are the 4 potential tests. And up to 20% of type 1s can have negative antibody status. And it's probably just because there's an antibody that we are not able to check for, right? So the C-peptide, if it's undetectable, is sort of your answer about their ability to produce insulin. And, now moving on to Dr. McKenna's clinical question, which is really what are the medication options and preconceptions, and how do we go again about counseling patients, especially in lower health literacy? And then, what about stopping medications or starting alternative medications prior to getting pregnant? And so, the second question we always ask everyone is what is her A1C goal for preconception? And we added preconception there because we always ask what is the A1C goal, because it's all about individualizing A1C goal. But in this case, we're targeting her A1C for preconception. So I'm going to throw that out to Emily. What goal would you be talking to her about in preconception?
In an ideal world, I would counsel patients to try to be less than 6.5 or even less than 6 if they can. I think for her, that is a very lofty goal. And, we have to also balance that with her age and, declining fertility rates over time, increased risk of miscarriage, etc. So, you know, in the 7s would be nice because certainly being in like the 9 to 11 range, she's at high risk of miscarriage and high risk of congenital anomalies as well. So, I would have a higher goal for her, just knowing that less than 6.5 is probably not realistic for her, and especially not in the time frame she kind of needs, given that she is 39.
I think those are great points, and that's just one way we do individualize it per patient. The other thing I just wanted to highlight in this slide is I know Dr. McKenna has already done this, but we want to always screen people for retinopathy and nephropathy because that can worsen in pregnancy. And so we do want to have those objective measurements, hopefully before people get pregnant. And then the ADA guidelines was also highlighting, and this might be not a bad option to do for her, screening her for undiagnosed sleep apnea, just because that can worsen hypertension in pregnancy and worsen diabetes control, overall, but also in pregnancy. So just one additional things, maybe not though, given all her other accessing the healthcare system difficulties, etc. And what then I was going to ask Emily is, and this patient and in all others during the pregnancy, what are you trying to aim for an A1C goal or glycemic goal?
Similar, we usually try to keep people below about 6.5 or even 6. For patients who have very frequent hypoglycemia or, significant hypoglycemia unawareness, often we'll kind of run those patients a little bit higher in terms of their blood sugars. So more in like the low sevens then. But, as normal blood sugars as we can is generally the goal, but somewhere, in the less than 6.5 for most.
Yeah. And I think what we have to highlight is the A1C is less accurate and tends to read lower because of anemia and pregnancy itself. And so that's why the A1C goals are so tight in pregnancy, and the glycemic goals are so tight in pregnancy. And I stole this slide from you, Emily, and in a setting of lower health literacy, how would you discuss this? And in your clinical experience, how have you gotten through to people that seem to not understand the increased risk for both themselves and their fetus because of the uncontrolled diabetes?
Yeah, I mean, I think it's really hard, and it sounds like this patient has definitely been thoroughly counseled. I just talk about, if we're talking about A1C, I try to just explain sort of what A1C is, but just broadly, I just generally talk about how having higher blood sugars, especially when they're, very high, which is shown by the A1C, that it can impact how the baby is growing and developing, and we can see risk of miscarriage, later pregnancy, risk of stillbirth. We can see problems with growth in the baby, babies being too small or more commonly too large, and then risk of birth defects. And especially with those elevated A1Cs, that could be, 1 in 4 babies have some sort of birth defect that's impacted due to those elevated blood sugars. And then reiterating that, all of these risks that we see can be lowered if we can help get the blood sugars under better control. But it can be really hard to do that type of counseling.
Yes, it is really challenging. And, we say we can modify, this is a modifiable risk factor, but sometimes it's so much easier to say than do. And so we just have to keep supporting them. And I think the other thing that I continue to find concerning is that it's not just in the pregnancy and early post pregnancy period for maternal fetal health. What we're seeing is the long-term potential risk for the baby and the child for obesity, diabetes, insulin resistance in those that have gestational diabetes or pre-gestational diabetes. And I think, that's ongoing, but it just sort of doesn't help us break the cycle of these family members that are struggling with obesity and diabetes. So, and I think we're learning more about that every day. This is sort of what I want to highlight and why I feel like it's unfair, right? This is a population-based cohort study for type 2 diabetes. And if you look at the rate of perinatal death in this particular study, the red is type 2 diabetes, you see that even in, sort of almost the A1C goal, so less than 7, 6.2 to 6.9, there's a significant increased risk of perinatal death. And then, at the levels of A1C she is at currently, there's almost a 10 to 12% increased risk for perinatal death. And so I don't know if a visual image like this would help her in any way to show like how many people, many babies die. And if there's a community member that lives with diabetes that may be able to talk to her about her experiences, if she's experiencing something similar. I know during my own pregnancy, I had a type 1, a very young woman who at 34 weeks experienced a death of her. And it was, a challenging moment for all of us. And so I don't know if by having that community and sharing that, it might be something that could help her. And then, the final thing is that not only do we look at A1C, we tend to look more at fasting blood sugars and 1 hour and 2 hours after eating. So our postprandial, because we need such tight control in pregnancy. The other way we can look at that is by the idea of time in range. And what I tell people is that unfortunately, the time in range for pre-gestational diabetes and specifically type 1 diabetes is 70%, but we actually don't have any particular goals by experts because of the lack of evidence in type 2 and gestational diabetes. But because I think of that, increasing complication rate, even at lower A1Cs, the expert opinion is that we should try to get a time in range, which is 63 to 140 in the type 2 population if possible. And you see, how challenging that could potentially be for this particular patient. And so, we always say the pillar, as we talk about it, is lifestyle, and then our medications are adjunctive to reaching our goals. It sounds like you've already had great discussions with her about nutrition. This was a particular website that I felt like was very nice about the just simple choices for eating. And I don't know if you could just use, again, visual images for her, focusing on filling the plate with vegetables, focusing on the health of the baby, and then also lean proteins for her, because the goal is to have, and they also have it in Spanish as well, which wouldn't apply to her in this particular case. But maybe doing a my plate discussion would be of some benefit for her. And I think the sugared beverage is, if there's any juice or anything that we can take from there, would help her glycemic control. And then pharmacologic therapy, you sort of already mentioned that there is some concern about appropriate medications in preconception and then in pregnancy. I think we all know that ACEs and ARBs are not indicated in the preconception or during pregnancy because of the risk of fetal birth defects. And then also, except for in severe familial hypercholesterolemia, we would not recommend continuing the statin, because there is this thought process that the cholesterol is used during fetal development. Emily, I don't know if you have any comments on that.
Yeah, I generally will stop ACEs and ARBs and statins unless people are particularly high risk, and the ACEs and the ARBs because of demonstrated fetal risk, and then the statins because of the theoretical risk, because we know that cholesterol increases in pregnancy and the fetus does need that for development. In this patient in particular, because she's 39, because it may take her some time to get pregnant, it would be reasonable to keep her on her statin and then stop it just as soon as she's pregnant. And I do that on patients on ACEs and ARBs as well, particularly if they have very poorly controlled hypertension. If I think it might take them, several months or a year to be able to conceive, and then have them stop kind of right away and then switch them to an alternative. Statins, I usually just stop during the pregnancy, and then antihypertensives, I'll switch to something more commonly used.
Can I comment on the statin thing too?
Go ahead,
So,
Erin.
yeah, I mean, statins are likely not teratogenic. So,
Mhm.
the FDA removed its most stringent warning label, and there's been now, since 4 decades of statin experience, a large body of observational data about women who accidentally became pregnant on statins, and we did not see any birth defects or anything like that. So, while we generally in low risk women will stop the statin before pregnancy, if a woman accidentally becomes pregnant on a statin, I just reassure her. But there's emerging data that statins may actually prevent preeclampsia, and there's some ongoing trials to show this. There's some small studies, about 100 women or less, where women on statins, actually had lower preeclampsia risk and lower NICU stays and things like that. So the pendulum might be swinging. So in my high-risk women who have severe FH, severe high cholesterol, or have established ASCVD, I'll usually restart the statin at 12 weeks, and usually pravastatin, or if they're very high risk, I'll continue them throughout, but I will actually reintroduce the statin back at 12 weeks for the very high risk woman. But otherwise, the lower risk women for CVD, I'll just keep them off the statin during their pregnancy and breastfeeding. But just don't fear using statins in women of reproductive age. They're likely not teratogenic, and she might not become pregnant for a while, and I would just keep her on her, because women who start pregnancy with high cholesterol before pregnancy, that's a big risk factor for preeclampsia and adverse pregnancy outcomes.
Yeah, that's definitely true. There's not been actually any truly demonstrated risk that we've seen from the statins.
Great expert opinion here. I love it. And so then the next, we've sort of talked about, all the pillars that we want to try to do to support her, optimize her glycemic control, have education about the counseling for those goals and why, and establishing a healthy lifestyle. And then there is the diabetes medication management. And, unfortunately, the answer is probably going to be insulin only for this patient. And my first thought is, would this person do an insulin pump given her uncontrolled diabetes? I think, given her health literacy and her barriers to taking medications, probably an insulin pump in preconception is probably not an option for her. But I do also want to just bring it up as we should be offering all the technology that's available to our patients to give them the best outcomes. This may not be the right fit for this particular patient. And so, our oral agents that are traditionally have been used and we have data on in pregnancy are metformin and sulfonylureas. What the ADA guidelines basically says is that in general, especially pre-gestational diabetes, usually these agents are not effective enough and the glycemic control escapes from them as insulin, especially as insulin resistance increases during pregnancy. And there is this risk because metformin and sulfonylureas across the placenta. And metformin is a little more controversial in there's been some data maybe that it prevents miscarriages in the first trimester, and potentially continuing use in the first trimester for PCOS would be beneficial. I think there is more data that sulfonylureas maybe have more harm in the sense they increase fetal hypoglycemia and then also macrosomia. And so, Emily, this is where, again, a very controversial topic. I'd love for you to weigh in about metformin and sulfonylureas in pregnancy.
Yeah, sulfonylureas, several years ago now, were kind of taken off the plate, if you will, for management of diabetes in pregnancy, primarily because of the increased risk of macrosomia and neonatal hypoglycemia. Metformin's still used. It is controversial, and depending on kind of who you talk to and what studies people look at, some people will say really insulin should be the only thing we are using. Others feel still very comfortable using metformin. I personally fall into the I feel comfortable using metformin camp. So this patient, I would feel very comfortable with her staying on metformin. However, certainly she needs more than just the metformin, assuming she is in fact taking it. And even if she's not, with an A1C that high, I still suspect she needs some insulin. And many people who begin pregnancy on metformin will need insulin at some point anyway. So counseling patients on that, but it does cross the placenta. We do know that. We do have some long-term safety data that doesn't suggest increased risk with the metformin. So it is, a discussion with patients, understanding that it does cross the placenta. But personally, I feel okay. I'm still using metformin and do use it pretty frequently to just help lower people's insulin resistance. But many, many, many people still need insulin. And this patient, it sounds like she definitely would benefit from insulin.
And Gail, I was going to ask you, do you have experience and do you use GLP-1 receptor agonists in the preconception period at all?
Yes, I have. And I was thinking about this particular case that she may be one, and once a week injection, maybe you can convince her. If she becomes pregnant, then you can take her off of it. And then, of course, she may still need insulin, but this may help her to lose weight and become pregnant. So I would definitely try that.
And for me, the balance is I often in a younger person will use a GLP-1 for 6 to 9 months in order for weight loss and to improve the glycemic control. And then I've had a few patients during their IVF treatments that I've started it on now because of the limited data. But my concern is if they're not used to insulin before they get pregnant, and then also in a person who is 39, we may not want to delay 6 to 9 months to get that weight loss because every 3 months, our ovarian reserve is lower, as I'm sure Emily can comment on. And so in this particular case for this patient, I actually said that insulin is my only recommendation because, she's 39. I apologize, I said 38 there. And we want to make her comfortable using insulin because she's going to become very resistant throughout the pregnancy. And so she is someone who's probably going to need intensive insulin therapy. And so I would try to introduce her with just a once a day insulin shot, but I would order premeal insulin because then, Emer, she will qualify for the CGM therapy. And I'm hoping that knowledge will be powerful for her, and so she'll be able to see her high sugars and have a more objective way of understanding the high sugars and how they could affect her and her unborn baby. And so this is what I would do, and then I'd have a low threshold just to start the premeal insulin with the CGM so then she can have an objective way of seeing what's going on when she takes the insulin. And I would want to start the insulin early so that she has comfort because this is someone who will be on very high doses of insulin during their pregnancy. What do you, then I'm going to throw it back to Emily if she has any other thoughts.
Yeah, I mean, that's my thought too, is that, trying to get her rapidly well controlled before pregnancy would be ideal. And she'll certainly need insulin in the pregnancy and likely a fair bit. I do think CGMs are such a powerful tool for people to really have like an objective thing to see and see how, meals and exercise and meds affect them. And it can be very hard to get them covered unless people are on multiple daily injections. So this would be my similar recommendation. I am seeing a lot more patients now with the question of GLP-1s and not versus not. And I think in the younger patients who do have somewhat of a luxury of time, I think it's great. And then I usually have people stop them like a month or two before they want to get pregnant so that we can kind of transition them to insulin if needed. Sometimes I leave people on up until they're pregnant and then just kind of transition at that point. But yeah, I do worry that it might be a rocky transition for her to do a GLP-1 and then switch to insulin as soon as she's pregnant, although I think it would likely benefit her to help with weight loss. And it may be more palatable to her because it's not, multiple daily injections. So, I think in this patient, either one is a reasonable thing to try because, there's a lot of nuance to her case, but.
Yep, great points, Emily. And before we go through the summary of our recommendations for this patient, I just wanted to bring it back to our overall metabolic health. And so, Erin, in this patient, if she wasn't in the preconception or even in the preconception, what would you be counseling her about her whole body health, given all her metabolic diseases at a young age?
Well, the biggest risk factors for an adverse pregnancy outcome is starting pregnancy and suboptimal cardiometabolic health. And so we really want to optimize the cardiometabolic health of reproductive age women because she's at high risk for preeclampsia. I don't know if she had preeclampsia with her other pregnancies, but certainly she's very high risk for preeclampsia. And, although preeclampsia increases the risk of morbidity around pregnancy and but it also, sets the stage for increased cardiovascular risk long term. And so, she has a very high lifetime risk of cardiovascular disease. And so we really need to optimize all of these things as much as possible and, getting her through pregnancy, but also to reduce her, long-term cardiovascular risk.
Yeah, I think that's great. And I don't know if she has anyone within the community that's had early heart attack or stroke that she could have discussions with, and or similarly, if there's anyone in her community that has potentially a child that has had a complication from the uncontrolled diabetes in pregnancy, so that we could make a very real world look for her and make sure she feels supported rather than shamed or stigmatized for her currently uncontrolled diabetes, which I think, Emer, it seems like you have been doing a great job balancing, supporting the patient, but also giving her very real world evidence and data, which is, I think, the art of medicine and our job and why we're having this great case discussion. So, for ease, I would just switch her to morning metformin, 2 tablets of the 750 in the morning. I had actually said stop the atorvastatin just because she's younger and so her cardiovascular risk is maybe less. And it didn't, I mean, she looked like she got down to 95 on a low dose of statins. So I didn't know that, necessarily she needed it as a higher risk person, but I didn't see what her LDL was before. So I defer to the experts and say, I think it'd be fine to continue her statin. And, if we can make some small nutritional goals, that will go a long way from her. And then I just think she has to get used to insulin. And so at a minimum, starting a basal insulin, ordering that prandial insulin so then she has access to the technology we think will help her. And then, as we've already talked about, if she was younger, I might do 6 to 9 months of a GLP-1 or GIP GLP for weight loss and for diabetes optimization, potentially with a lower dose of basal insulin, just so that they are used to insulin, and then replace it with prandial insulin, 3 months before. And I will definitely say I had one patient who we did that, and she was rapidly on large doses of insulin, even in the preconception phase after I pulled off her GLP-1. So it is just something they have to be aware of. And I'm going to give it to Emily as the final thoughts as our maternal fetal medicine expert. Any final thoughts?
I agree. That is really, I don't think I have anything else to add. And then sometimes it's helpful to have them be seen by like an obstetric provider in preconception, if that's just like another ear to kind of hear the counseling as well to sort of reiterate things. But yeah, I agree with all these recommendations.
And I think this is where we say this is a team effort and we just all want the patient the best and to support the patient. And so I will say this formally ends session 12 of the Cardiometabolic Echo.